Hi guys. One more time, we're going to do one more video tonight. I'm going to transfer my screen and we'll get started on colon cancer. I've changed the PowerPoint from what was originally posted. So please feel free to look at the new one. I took out several slides. I'm going to try and streamline this material for you. So colon cancer. Okay, colorectal cancer. So, about the third most common cancer type in our country. We looked at how lung cancer had more fatalities, but breast cancer and prostate cancer were more common, followed by colorectal cancer. So it is one of the top three. So I do want to spend a little bit of time talking about it for you. It's a solid tumor, so it fits within the exemplars of this unit. Again, the third most common cancer in the U.S. behind breast and prostate. In 2012, we're looking at 150,000 new cases. Over 1 million people living with colorectal cancer at any time. It's something that's probably touched a lot of people in your life. Most of the time this happens to our middle-aged adults and older. Most cancers, I'm sure you realize by now, happen as we age more commonly. The country with the highest incidence of cancer in our world is Japan. They also have the oldest population in the world. So it kind of goes hand in hand. But 90% of colon cancers happen in middle-aged and older populations. Happen commonly in Caucasians and Black Americans, a little less common in Asian, Hispanic population. A little bit more men than women. Highest incidence in the Black population. So we know that people with family history of adenomatous polyps, adenoma means glandular tissue. Most colon cancers evolve out of epithelial adenomatous tissue, so glandular tissue in the epithelial cells of the colon or the rectum. And out of those arise a polyp. And those are the most common conversion to malignant tissue that we have. So if you have any family members who've had adenomatous polyps removed, if you have or somebody else in your family has, that gives you an increased risk of colon cancer. We also know that there's a disease called familial adenomatous polyposis. And if you have that ongoing familial, if there's a familiar that condition of abnormal familiar adenoma polyposis, it's hard to say really fast, then that can certainly, those patients are a lot more likely to have colorectal cancer, even though it's only 1% of all colorectal cancers. If your family has that, there's a family history, your chances go way up. We also know that Lynch syndrome can make you have an increased risk of colon cancer. Lynch syndrome is a syndrome of non-polyposis colorectal cancer, but it also predisposes the patient to 5 or 6 other kinds of cancer: ovarian, endometrial, brain. And so that particular Lynch syndrome that runs in families can increase your risk of colon cancer as well. So here's pictures, the familial adenomatous polyposis. You can see if you have that family history, what that looks like when it comes to your colon. Look at all those polyps, a condition of massive adenomatous polyposis. And that those people have a lot of colon cancer when they have that kind of syndrome. And then Lynch syndrome, of course, putting you more at risk for colon cancer, but also stomach cancer, uterine cancer, ovarian cancer. So polyps. Polyps can be hyperplastic tissue, just an overgrowth of tissue that comes out of the mucosal wall of the intestines. But if it comes from adenomatous tissue, 90% of all colon cancers come out of polyps that come from adenomatous tissue. So if you have one of those polyps, those are more likely to be cancerous polyps. Picture of what they look like: normal bowel tissue on the far left, cancerous bowel tissue on the far right, and a picture of a polyp. And you see it's pedunculated, it's footed, in the wall of the bowel on a stem that sticks up a little polyp on top of it. And what they'll do is actually, if we can remove these, we can dramatically decrease your chances of developing carcinoma. That's why we do colonoscopies. A colonoscopy will identify those polyps and we can remove them. And if we can remove them, we can prevent cancer. There's about some 7 to 12 years time between the development of a polyp and the development of it becoming malignant. So if we can take out these polyps early, we can actually prevent the malignancy. And remember, it happens after 50. So that's when we start doing colonoscopies at 50. We want to start watching for that, removing these polyps, and we can dramatically decrease the chances of developing breast cancer. I mean, not breast cancer, colon cancer. 40% of colorectal cancers are detected in the earliest stages. What we know, these numbers are actually a little bit old. These come out of 2012 statistics, so I need to update them for you. But we know that only about half the people in America say they've had colorectal screening after the age of 50. We're getting more and more numbers out there. We're having more TV commercials about it. It's becoming more acceptable to talk about. I love the little semicolon joke over here on the right. We know that there's not as much awareness, but people like Sharon Osbourne, Ozzy Osbourne's wife, when she came out publicly and started talking about her colon cancer, sometimes having a celeb make statements about it can legitimize a disease and cause people to talk about it more with less embarrassment. People don't like to talk about their colon because it is an uncomfortable subject. But Sharon Osbourne came out in 2012 and announced that she was a survivor from colon cancer, and she'd had extensive surgery. They'd taken lymph nodes. Since that time, she just had, as a matter of incidence, in 2012, she had double radical mastectomies because she carried the genetic link for breast cancer. So she's been redesigned to get rid of her cancer risk. So there are various types of colorectal screening. There's DNA testing, where the patient eliminates a stool into the toilet, and not into the toilet, but into a collection device. We pack up the stool, send it off for testing, and they look for DNA of cancer cells in that stool. Polyps and cancer shed abnormal DNA in the stool continuously, so that kind of screening is pretty reliable. We also do hemoccult screening, blood in the stool, looking for blood in the stool, where we actually put a smear on a slide, put a developing solution on it. If it turns blue, there's blood in the stool. And that is colorectal cancers. Almost all of them cause bleeding into the colorectal system. So that may not be frank bleeding. If it's frank bleeding, that obviously could be a problem too. But if it's occult bleeding, that's often a sign that you have a polyp up there that's bleeding, or a rectal cancer that's up there. The middle picture that's all white is a barium enema, where we use that chalk-like barium stuff to outline the lining of the bowel wall. We're looking for tumors and masses in the bowel wall. The farthest right picture comes from one of those cams that you swallow, the endoscopy cams that you swallow, and it takes pictures all the way down. Pretty good resolution on those pictures, and you can see that polyp that it's identified. So the cancer screening tests are divided into tests that identify cancer itself and precancerous polyps. And then you have screening tests that just simply kind of look for cancer. We're not identifying the polyps. What the recommendations are is that people have both tests. So the colonoscopies and the endoscopies, when you swallow the cams, those are the tests that look for polyps and detect cancer. The hemoccult screening, the DNA tests, are simply cancer screening detection tests. So to find things early, we're saying that you should have your colonoscopy, have it every 5 to 10 years after age of 50, and then annually you should have your fecal and occult blood or DNA testing done. So when we're looking at colorectal screening, we're doing not just a colonoscopy, because that would look all the way out, but we also can do sigmoidoscopies, where we just look at the sigmoid colon. And then a double contrast barium enema can also be equally effective, although we find that we're doing more colonoscopies than barium enemas. Barium enemas have a little bit of after residue. They can that barium can bind up in the colon and make it hard to have a bowel movement. The patient has to pass it within a couple of days, 72 hours after the treatment, and there's always the risk of becoming constipated. So we really just, we still do barium, but we're doing colonoscopy so often now. That's what we're doing more often. But less invasive, fecal occult blood, DNA testing, or the virtual colonoscopies with the cameras. This kind of covers the same stuff. So it just shows you how the picture on the bottom left just shows you how on colonoscopy we'd see the polyp and then we'd snag it. We'd put a little loop around it and we'd excise that polyp. We might biopsy it. Sometimes they just take the polyps out. Sometimes they have to put a little suture in to stop the bleeding. Sometimes they don't. But polypectomies are pretty common during a colonoscopy. So here's the endoscopy colonoscopy showing pictures of what it looks like with the camera. So the image from the camera is on the left. The image from a regular colonoscopy is on the right. So just a little joke, not the stool sample I had in mind. So fecal occult blood tests look for blood in the stool. It's not as specific. The DNA is a little bit more specific because it looks for the abnormal DNA from the malignancy or from the abnormal polyps. Blood can be from a variety of different things. Hemorrhoids can give you blood. Irritation, sometimes diverticulosis can give blood. So again, this is the DNA sample where you'd save your stool, package it up, and send it off to the company to do the DNA testing. When we do identify colon cancer, we do the staging and grading of it just as we do other cancers. And I think there's a better picture of this in a minute, so we'll talk about it. A lot of different people are touched by colon cancer. I guess Supreme Court Justice Ruth Bader Ginsburg, who's in her late 80s now, she's had colon cancer for almost 20 years. Well, no, that's not 20 years, like at least 99, 2000, yeah, almost 20 years. And she's still a survivor, working out every day. The Peanuts, Charles Schultz, the guy who did Peanuts, he died from colon cancer. And of course, we already talked about Sharon Osbourne. Again, it's an uncomfortable topic. People don't like the prep for a colonoscopy. They don't like those bowel preps. They also, some people just avoid going to the doctor. They don't want to know. I'd rather just not know. If something's bad, it'll show up. And until then, I just don't want to know. And that's why cancers are identified late. So most colon cancers happen low in the colon. The picture on the left shows you the percentage of cancers that happen in that area. So if you take anus, rectum, sigmoid, and descending colon, you're looking at 58, 68, you're looking at a little over 70% of your cancers just happening in the lower part of the left colon. Almost all colorectal cancers experience bleeding and a change in bowel habits. So remember the CAUTION acronym that we went back over in the first lecture? I think it was the first lecture. We taught one of them was a change in bowel or bladder habits, and another was unusual discharge or bleeding. And so if you have blood in your stool or a change in your bowel habits, those are two things you'd immediately want to go get checked out and test for colorectal cancer. So again, most of them come out of polyps, but diet and lifestyle have a lot to do with colorectal cancer. We think about 35% of all cancers of the colon are attributable to the patient's diet. And that means dietary modifications might be able to prevent colorectal cancer. So what do we know are the risk factors in our diet? Increased red meat, lots of animal and saturated fat intake, refined carbs like white breads, sugars, simple sugars, and alcohol intake all increase your risk of colorectal cancer. What decreases your risk is having lots of dietary fibers, eating fresh fruits and vegetables, eating a lot of antioxidants. Remember, those are vitamin C, vitamin E-rich foods, calcium, and folate, the B vitamins in your diet, all can decrease your risk of colon cancer. So a healthy, high-fiber, vegetable and fruit-rich diet are all going to help you prevent colon cancer. So again, the symptoms, the first two I mentioned, a change in bowel habits and blood in your stool, pain and abdominal discomfort can happen, and weight loss happens in a percentage of people too. So the colonoscopy is one of the first tests we want to do. We'll look at the whole colon, identify if we see abnormal tissue. A blood test we'll do is the CEA. We talked about cancer surface antigen. CEA is certainly one of them. It's very common in colorectal cancers. So everybody has a little bit of CEA in your bloodstream. There's actually a normal value, but in colorectal cancer, that number goes way up. Cigarette smoking can alter your CEA and give you elevated CEA levels even in the absence of cancer. So if you've got a smoker, you know that your test results may be slightly off. But elevated CEA levels are a tumor marker for colon cancer. That's important for you to understand. And of that, we can do CAT scans, PET scans, looking to see if the cancer is spread. We're certainly going to do surgery. We're going to do biopsies of the tumor, and we're going to remove the cancers. And possibly we might have to put in a colostomy, sigmoidostomy, or some other kind of bowel diversion device while they heal or while we undergo treatment. So we know from our other lectures in cancer that we can do TNM staging and grading. So we look how big is the tumor, how far does it extend, is it in the lymph node, and has it metastasized? And then we can stage these. I know that picture I showed you earlier, this was a small picture earlier in the PowerPoint. It shows a stage 0 cancer would just be in situ, confined to that polyp only. Stage 1 into the lining of the bowel wall. Stage 2 up into the musculature. Stage 3 through the bowel wall. Stage 4 into the lymphatics or blood vessels. So we're just going to grade and stage our cancer like we do every other cancer. We know that colon cancer can metastasize. And one of the most common types of metastasis in colon cancer is when it butts up next to a neighboring organ, so into the abdominal wall, into blood vessels or nerves that are in the abdomen, the peritoneum. It can also metastasize through blood or lymph to other organs. So we know that we're going to get our full treatment team together to discuss the treatment between the medical oncologist, the surgical oncologist, and the radiation oncologist. We're going to get a full treatment plan, get a nutritionist and a social worker on board, a patient navigator to help the patient navigate through the complexities of insurance and the complexities of the healthcare treatment facilities and what they have to do to get from point A to point B. So patients' preference are certainly going to have something to do with it. Where they're at, is it a rural hospital, or are they going back to a large teaching hospital, or is it a research hospital? All those things are going to influence the type of treatment they have. So this is just good advice for all of our patients. Keep a list of questions, carry it with you to your appointments so you can remember to ask everything. Keep the list so you don't just say, oh, I'll remember to ask them that, and then you forget. Remember that you need to write down and document side effects, adverse effects. Make sure you know what meds, over-the-counter, herbs, alternate remedies, any supplements you're taking so that they can be fully aware of the interactions of all your drugs. And find out the best way to communicate with your team. Who do you contact first, and how do you do that? Do that by telemedicine? Do you do it by email, by phone call? If it's an initial cancer diagnosis, the patient's going to be pretty upset and they're not going to remember anything they said. So it's a good idea to have a support person with them that can help them, drive them if they're upset, and also can help them remember what was said and what was taught. So remember, like all cancers, our goal is to get rid of the cancer, kill the cells, and keep it from coming back. If we can't do that, then palliation, slow the growth up and help the patient have the highest quality life possible. So like all cancers, surgery is usually our first choice. We can do that through a laparoscopic surgery, or we might have to do an open abdominal surgery where we actually resect large portions of the bowel. If they have to have a resection, a colostomy is possible, depending on where in the bowel it is. Sigmoidostomy, transverse colostomy, so we'll just ileostomy, depending on what part of the bowel is affected. We'll follow that up with chemotherapy. And with rectal cancer specifically, chemoradiation works really well. That's chemotherapy given while the patient's getting radiation therapy, and doing both simultaneously. It's called chemoradiation therapy. Works particularly well for rectal cancers. We are using biologic treatments, growth factor suppressors, and other treatments that affect growth factor. We're looking at anyway, we're looking at the biologic treatments. I'm sorry, it's really late. It's really that I'm getting tired. My words are starting to slow together. So clinical trials are always out there, and we're constantly doing clinical trials. If somebody enters a clinical trial, they are not guinea pigs. They're doing it by choice. They just don't know if they're in the placebo group or in the test group. Because a good double-blinded study, we will never know. The nurses administering the meds won't know if they're administering the placebo or the actual drug. So it's truly a blinded study. So we can't get mixed up with knowing, oh, I'm telling you, hint, hint, nudge, nudge, this is the placebo or this is the real thing. We don't get that Hawthorne effect with patients. They know they're in the case and they think this is what they're getting, so that automatically changes the way they feel. So the most common chemotherapy for colorectal cancer is folic acid with 5-FU and irinotecan, and which is the topoisomerase inhibitor. We've talked about that as a category of drugs. Irinotecan because the major adverse effect is diarrhea. Don't you love that? But let's talk just a little bit about each of these drugs. Again, I don't expect you to remember specific chemotherapies for specific disorders, but I think it helps to talk about some of these disorders so you get a global picture of chemotherapy and how it affects the patient. So if you're presented with a patient, I say, oh, that patient's on 5-FU and vincristine, you don't have to know that drug, but you'll recognize it's a chemotherapy. So leucovorin rescue, this is folic acid. This is a nutrient. It's good for us, right? And we use it for many different things. It can be used to rescue a patient who's got a toxic dose of methotrexate, another chemotherapy. It helps to protect the cells from the toxic effects of methotrexate. And we can use it as a treatment for anemia because folic acid is an essential element in red blood cell formation. But in the case of colorectal cancer, folic acid, leucovorin, increases the effects of the 5-fluorouracil. It helps the cancer chemotherapy that we're giving act better. So 5-FU can be pretty toxic, has neurologic and blood toxicities. So you can expect to have a lot of complications and side effects for your patient. Another drug we give in this combination is oxaliplatin. The platin drugs made from platinum all cause nausea, vomiting, super big problems with the platinum drugs, as are the hematologic toxicities, the penias, thrombocytopenia, neutropenia, thrombocytopenia, anemia, all the way around. And then because of those penias, neutropenia, we absolutely end up getting low on neutrophils, our warriors for the white blood cells. And so these neutrophils are the main protectors of infection. So we actually look at the absolute neutrophil count. We've talked about it before. Do not have to remember how to calculate it, but you do want to look for it on your lab results. And if you hear it talked about on the floors or in the doctor's notes, you want to be aware of what it's talking about. If your absolute neutrophil count gets below 500, the patient is going to go on neutropenic precautions because they're at risk for infection. We talked about that on another slide. I can't remember which one, but on one of the other slides. I think it was probably in the leukemia set. Thrombocytopenia is a low platelet count, also caused from these hematologic toxicities. And we talked earlier, also on the leukemia slides, if your thrombocytes get below 20,000, you're at risk for spontaneous bleeding, which means strokes, ocular bleeding, bruising, nosebleeds, and so they go on bleeding precautions. And then anemia Different hospitals are going to do different things. It's pretty much standard of care if you get below 8 that we at least consider a transfusion. So if your patient gets a transfusion, 1 unit of packed cells will raise your hemoglobin by 1 gram per deciliter. So if you're 8, you get 1 unit, you'll be 9. So quite often we'll give 2 or 3 units. Okay, oxaliplatin, this drug causes a lot of peripheral neuropathies, and the patient becomes very sensitive to cold. So they're not supposed to touch anything that's cold for 5 hours after they take this medicine. Don't pick up a cold soda pop. Don't go out in cold weather. Anything that's cold. Don't touch an iced drink. Don't touch cold countertops. So just be very careful about touching cold stuff. It can then cause difficulty speaking, laryngospasm, making it difficult to breathe. That can actually cause airway problems. But peripheral neuropathy is also a problem from a lot of chemotherapies, the numbness and tingling from the nerve damage. We were talking about clinical trials. There's phase 1, phase 2, phase 3, and phase 4 clinical trials. Phase 1 is when we go first into testing. That's what the vaccines for coronavirus are right now. We've got a vaccine out there that's in stage 1 testing where we're just, is it safe? Is it killing people? We're going to do animal studies first, then human studies. Then we look at efficacy. Is it safe and does it work? And then we start putting it in larger groups of human populations. Phase 3 and phase 4 clinical trials, much more common in the healthcare world for us to be engaging in. So again, always with informed consent, always, always, always. The patient knows that they're in a trial. They know the risks and the benefits. Okay, so side effects from surgery. This patient's going to have pain, of course, a surgical site that has to heal. They're going to have a scar, usually on their abdomen. They might have, if we've removed rectal sphincter, then they might have incontinence. We can do a J pouch, which can give them some continence back. We can also do an ostomy, and we can have continent ostomies where we use ileal conduits and other types of making a sphincter that the patient can catheterize and eliminate. So it's not always draining, but they have a little bit more control. Other problems are the side effects from chemotherapy, which have been over and over: diarrhea, mucositis, neuropathies. Of course, allergic reaction can happen with any medicine, but certainly chemo is pretty toxic. Radiation, there's the skin damage, the skin problems that come from it. Plus, this patient has bowel cancer, so we're irradiating the entire pelvis. That might give them incontinence as we cause inflammation and radiation damage to the bowel and bladder sphincters. It also can give them erectile dysfunction and sexual difficulties because of the irradiation of the gonad organs. So life after treatment, it might mean living with a colostomy. It might mean all the emotional upheaval of having cancer, that anger, loneliness, overwhelmed, all very common with cancer. We've talked about that in other units. I like this PowerPoint because it has quotes from survivors in it, so it talks about how that felt. So open communication with your family, with your doctor. It sounds embarrassing, but you have to learn to talk about it. It's the only way you're going to get straight answers and clean communication. Humor and laughter is healthy, and it's just because someone's laughing about it doesn't mean they don't take it seriously. So nurses, doctors, and patients all sometimes use humor and laughter, and we think it might sound inappropriate. It's a way of coping. It's a way of maintaining hope, and it can help with healing, and it can help with understanding. So we're going to use those tools. Colorectal cancer, because of the chemotherapy, because of the surgery, because of the radiation, does cause quite a few sexual problems. And it's just very important for the partners to be upfront, open, and honest with each other and with their provider, because sometimes there's treatments that we can give them. So again, after your treatment, after your surgery, after your radiation, we definitely want to do healthy living, working out, eating healthfully, drinking lots of fluids, maintaining your mindfulness and your spirituality, reaching out to within your faith, to the God that you're praying to, having a personalized care plan, mobilizing all your support systems. That's important during and after treatment. So, like all cancers, the patients are going to fear the risk of it coming back. One thing about colon cancer, it happens after 50. There's a long time period between the development of the polyp and the formation of cancer. Again, 7 to 12 years. So if you get your cancer at age 60, 12 years later is 72. But if you get your cancer at 72, 12 years later is 84. If you get your cancer at 78 or 80, 12 years later is in your 90s. Sometimes when the patient is old, we don't always treat the cancers aggressively because the time frame for life and death, their own natural lifespan may expire before the risk of the colon cancer will cause them to die. So there's certain things we think about that in context of the medical team, but you want that patient to be active, don't let anxiety get to them. And if you have a tenure to the initial problems and then we treat it, and then 10 years later, usually that patient is older. There are a few cases that come on younger, and usually that's when there's family history, familial polyposis. Okay, that's it. A world with less cancer is a world with more birthdays.